Welcome everyone to radiation and liposarcoma, when, how, and why it matters. We're going to give everyone a minute or so to join, and then we'll start our presentation. All right, my name is Tara Ruggiero. I'm the program coordinator for the Liposarcoma Support Network. During this webinar, all participants will remain in listen-only mode. You'll have the opportunity to ask questions during the Q&A session at the end. Please submit all questions in the Q&A section, not the chat. Please note this information shared in today's webinar is for educational purposes and should not replace guidance from your own physician or healthcare team. We're excited to have Dr. Katie Lee with us today. She's an assistant professor of radiation oncology at the Mayo Clinic in Rochester, Minnesota, where she specializes in the treatment of sarcoma and thoracic cancers. Dr. Lee completed her MD and PhD at Harvard Medical School and her radiation oncology residency through the Harvard Radiation Oncology Program. She is deeply involved in improving how radiation therapy is used for sarcoma, with a focus on making treatment more effective while reducing the side effects. She is passionate about combining thoughtful, compassionate care with innovation to improve outcomes for patients and families. We are honored to have Dr. Katie Lee with us today and grateful for her time and expertise. Today, she will present radiation and liposarcoma, when, how, and why it matters. Without further delay, please join me in welcoming Dr. Katie Lee. Thank you.
Thank you so much, Tara, for the kind introduction. I'm excited to be joining you all today to talk about radiation treatment in liposarcoma, to kind of give us a primer on what we're talking about and to talk about future advances as well. And so this is just, Mayo has us have a headshot, and also I have a Twitter handle in case anyone would like to reach out afterwards and ask further questions. Okay. So what is the background of liposarcoma and radiation therapy? And I know this group is well aware of that soft tissue sarcomas are a really rare form of cancer, making up only less than 1% of all cancer types. Within sarcomas, there's over 100 different subtypes, and liposarcoma is one of those subtypes. It's forming from what we think to be cancer, or cancer from fat tissues. But really, we can even further divide it by histology. There's well-differentiated liposarcomas, dedifferentiated liposarcomas, myxoid and round cell liposarcomas, and pleomorphic liposarcomas. And this matters to us as radiation oncologists because it does change how we think about these diseases, as they have different biologies as well as different clinical patterns. The other big way that we further differentiate liposarcomas is by their location. And as a specialty, we think about location a lot since we are a local treatment. And so those are things like we group together the extremity and trunk, and then really the retroperitoneum, abdominal, and pelvic cavities. And so radiation oncology is one of the pillars of cancer treatment. I think every time I look up this graphic, they continue to expand the number of pillars, but really surgery, radiation oncology, and medical oncology are the specialties that have traditionally formed kind of the cancer treatment paradigms. I think of surgery and radiation oncology as being a local treatment, and so really focused on the tumor itself and its surrounding areas. And then medical oncology and some of our other interventionalists focus on systemic treatments, and those are the ones that go throughout the body, things like chemotherapies, immunotherapies, and molecular targeted therapies. And so in radiation oncology, we're this local treatment. And with that comes how can we play a role in someone's cancer care? And really, we're in three different role groups as a patient has cancer. One is with curative intent, so to try to eradicate a tumor completely into remission. Sometimes we're used for control of a tumor, so inhibit tumor growth or spread when we aren't able to fully cure. And then also in the palliative setting, where symptoms from a tumor can cause distress or pain. And so this can help reduce pain, especially when other therapies aren't viable or would be too toxic. Radiation therapy, so it's a local, non-invasive therapy. I like to think of ourselves as surgeons without a scalpel in some ways. And we treat patients mostly with ionizing radiation. So when you hear the term radiation therapy, we can think of it mostly in the term of a form of energy that's causing ionization. For all cancer patients, almost 60% will receive radiation at some point during their course of their disease. And within sarcoma, this can be even more. Really, radiation therapy is a custom-tailored therapy to a patient's tumor location and their personal anatomy. So how does radiation work? So radiation therapy is actually a lot of complex biology that we've known about for since kind of ionizing radiation. And Marie Curie even sent letters to the Mayo Clinic to discuss the role of radiation as she was giving radium to her hospital. And what we know kind of from a historical perspective is that radiation, when given to cells, causes DNA double-stranded breaks. And normally, healthy cells are able to repair that DNA. They have the typical kind of complexes and proteins that are able to repair it and then go on to generate more healthy tissue. However, cancer cells, even though they're described as being uncontrolled growth, are really actually quite sick cells and are susceptible to this DNA double-stranded break. And so when you cause this DNA double-stranded break, they're not able to heal. And so that damage causes the cell to not be able to replicate and actually die, thereby causing our ability to kill cancer cells. The hard thing, though, is that usually tumors are surrounded by normal tissues. And so radiation beams can damage both normal and cancerous tissues. And so we have to think of a way to help save those normal tissues while killing the cancer cell. As I said, normal tissues generally heal from radiation better than cancerous tissue. And tumors can be at different depths of the body. So how can we get radiation into such a way that we're able to kill a tumor and keep the normal tissue? And so this is really how we kind of harness radiation therapy, is that we apply really complex physical principles with advanced technology in order to be able to kill cancer cells while preserving normal tissues. How can we do this? So your radiation oncologist may tell you, we are going to have you come in for 5 weeks of treatment coming Monday through Friday. And this is going to be how we prescribe our radiation. So we're giving you daily treatments every day for a period of sometimes multiple weeks. And why is that? So each fraction or a treatment we are able to give. And with that, we are able to kind of damage the cells, and normal tissue cells will be able to repair, regenerate, and get ready for that next treatment of radiation. However, cancer cells aren't able to have that same sort of repair, and so lessen in number. And as we do this, we're able to kind of divide the normal tissue cells and the cancer cells, where the normal tissue cells are able to survive and the cancer cells are able to die over time. The other thing that we know is that, unfortunately, that this normal tissue cells having this injury with radiation can cause you some acute side effects. And so that's why those side effects will grow over time as those weeks progress. But over time, after radiation is completed, those normal tissue cells will regenerate and those side effects are to get better. So again, we're always thinking as radiation oncologists, how do we balance tissue injury and tumor kill? The nice thing is that we've actually had a lot of advances in technology, with the advent of computers, imaging, and better understanding of these physical principles. We've really been able to further harness into our physical principles and kill cancer cells more preferentially. early radiation, like when Marie Curie was sending those radium beads, it pretty much was anything that was exposed got a full toxic dose, and normal tissue and tumor all had kind of similar large amounts being treated. We then had 3D radiation therapy, so we were able to take an image and at least shine a box on where we wanted to go. And so that decreased the amount of normal tissue that was getting radiation. Now, however, we have image-guided radiation therapy. Some people will hear of stereotactic body radiation therapy. We have ways of monitoring tumor motion as things move in the body. Things aren't static. Our lungs move, our diaphragms move. And so with that, we're able to better kind of guide where that radiation is going. The other thing is that we have physical properties of the radiation where we're speeding things up to the speed of light and then changing and creating molds in order to create conformal radiation treatment fields. So rather than just a box, we're actually shaping it to the tumor itself. And this really helps with decreasing side effects while increasing our ability to kill those cancer cells. The other big advance has been the use of particles. So what we've been mainly talking about and what most people will hear about in radiation treatment is photon-based treatments. And those photon-based treatments utilize X-rays that pass through the body, similar to if you're getting a chest X-ray or a CT scan, and causing that DNA damage. The downside is that they kind of travel throughout the whole body and have a low dose bath that comes in and comes out. Now we also have proton beams, so these are particle-based therapies. The proton beam actually comes through, damages those cells, and then stops. Carbon ions are kind of the newest kid on the block. They're available in Japan and Italy, and will be coming soon to Mayo Jacksonville. And you can think of these as even bigger protons, causing even more damage. And we're not sure exactly how all of their biology still works, but it has an exciting opportunity for potentially, especially in sarcoma. So photon radiation, again, those are those big, powerful X-rays. They're produced by a linear accelerator, as you can see here. They're shaped by modulating a beam, and this treatment head goes all the way around the patient in order to create these extremely conformal or curved out plans. And they can deliver therapeutic doses of radiation deep into tissues and sparing those normal healthy tissues around it. Proton radiation, on the other hand, is that particle, and it comes to that abrupt stop known as the Bragg peak. It spares distant normal tissue, and this has been especially shown to be helpful for children since their healthy tissues are still developing, and you can think of them as having lots of stem cells that still need to go on to differentiate. So where a photon plan to treat like the entire brain and spinal cord axis would have to give low dose to some of those anterior structures, so things in the front like the heart, the esophagus, the liver, the abdomen, and the gut, are able to be stopped with protons. So then always comes the question, why aren't we able to give protons to everybody? Isn't it a better treatment? But with protons, we still have quite a bit of ways to go. We don't fully understand how they stop and where that exact end range is. With any sort of motion, they can be very particular. And so they will just kind of fly through the lungs. And if there's a little bit more motion that day, can have an uncertain where they're stopping. Our onboard imaging still needs to be further developed for protons, and it is a limited resource. So what the patient will see is in this treatment room, kind of where the treatment head is, and then it goes around the patient. And what is actually behind there is a cyclotron generating large electron fields to 2/3 of the speed of light to accelerate these protons. Large magnets that then will move the protons to the patient. And actually there's over 200,000 pounds of gantry that's required to move that treatment head. So here's the patient in that whole apparatus. So while you may see this in the room, there's actually football fields worth of machinery deep down into the earth that are helping create this. So what are the steps for radiation delivery? So first you'll meet with a radiation oncologist whose goal is to help determine if radiation is the right fit. What's the goal of us giving you radiation treatment? Um, what's the plan for the radiation, and will it help your cancer? We then will acquire a planning or a mapping scan, as you may call it, and that's where we have you in a reproducible position with a CT scan to help guide how we deliver that radiation treatment. At that point comes the design, and so this is a treatment plan that's based off of the planning scan, as well as any other imaging that you've had in order to design where that radiation goes, and also importantly, where the radiation does not go. And then we deliver the radiation, and that's with you in that same exact position every time, and it's used in as we did in that planning scan. And so I always tell patients that radiation plans are an iterative process. So we'll get that initial planning scan, and then the radiation oncologist will contour or design where that radiation is going, where the microscopic disease could be, and to allow for any uncertainties in a margin around the treatment area. We then design with the help of a whole team the radiation dose and go back and forth in a few different times in order to fully optimize where we want the radiation to be and where we don't want the radiation to be. As I said, radiation oncology, we're a whole team of individuals that come together for radiation treatment. It's probably one of the more unique departments within our hospital in that we engage with a lot of different specialties and role groups that aren't traditionally learned about. So there's the attending physician, such as myself, and you can think of us as the captain of this large ship. We work with residents, nurse practitioners, physician assistants, and nurses to help you through all of this treatment. And then we also have radiation therapists, and they're the ones who are actually licensed to administer the radiation. They go through specialized bachelor's and associate's degrees in order to be able to do this with certificate programs and then their own board examinations. Medical dosimetrists who also have master's levels of where they are designing radiation treatment plans and also go through certification. And then medical physicists who have masters or PhDs in physics who then do a medical residency in radiation oncology with goals of understanding treatment planning and are responsible for the majority of our QA or making sure that the radiation treatment machines are doing what we think that they're doing. And here at Mayo Clinic, we're able to have those machines delivered within 1 millimeter of accuracy. So that's a lot of nuts and bolts regarding radiation treatment and what all goes on behind the scenes. So why is it important for liposarcoma? And so this is really, we'll break it down into two different parts for those in the extremity setting and those in the retroperitoneal setting. So we can think of radiation as being a way of getting to places that maybe a surgeon cannot, as well as for thinking of microscopic disease. So for example, we have a tumor here. There's a kind of a bulky tumor area, but then we know that little cells of this tumor will verge off into the periphery and try to escape kind of that typical environment. So we can use a scalpel and cut out that bulky tumor, but there may be microscopic residual cells that are left behind. One option for kind of being able to get around that is to do a bigger resection, so getting a bigger margin and thereby getting all of those microscopic cells. But as you can imagine, very large resection cavities are not so practical, especially for areas that are really important, where we don't have a lot of extra tissue. So what's a different way that we could go about it? So radiation can treat a field to account for microscopic disease that won't have as big of implications as a larger surgical resection, and it can treat difficult regions of the body to access. Things that we don't want to take out a lot of. For example, if there's a big thing in the lung, we maybe not want to take out a whole lobe or the whole lung and instead just treat a smaller area. Or the surgeon may say, oh, I can get this smaller area, but I'm worried about disease being left behind. And so these are all things that we're thinking about with the usage of radiation in conjunction with our surgical colleagues. So one way is to cut it out and then give radiation afterwards. So get the microscopic cells if there's a positive margin, give a bigger area and a higher dose in order to get rid of those microscopic cells. And these are things that we call like postoperative or adjuvant radiation treatment. And then our goal is to have no residual disease after that postoperative radiation. Another way, though, to do it is to give preoperative radiation. So apply a smaller field with a smaller dose to the tumor and a microscope and the area that we think has microscopic disease, and then get rid of that microscopic disease. We're usually, especially in sarcoma, not able to kill as many cells within the actual bulky tumor, and then have a surgical resection that's a little bit smaller and allows for no residual disease at the end of treatment. So what's the data to suggest that we should be doing extremity radiation treatment? So in the 1970s, they asked the question, can radiation therapy be used for limb-sparing resections in sarcoma? The standard of care kind of before this was actually to do very extensive surgeries, including amputation. And so that was really thought to be the only curative approach. So the NCI with Dr. Rosenberg did a study from the 70s into the early 80s that compared amputation to wide oncologic excision with radiation therapy. And what they saw was that there was no difference in local control or overall survival. So the oncologic outcomes were really the same for those patients that had an amputation versus those who had surgery and radiation therapy. And so really this became the standard of care that limb preservation for high-grade extremity soft tissue sarcomas would be employed to spare the sacrifice of limbs in the treatment of sarcoma cancers. And this was the next question that they asked in the 80s into the 90s. So, okay, we're able to spare limbs. Do we actually need the radiation in addition to the surgery itself? And so the NCI, again, asked this question. They randomized patients to either getting radiation or no radiation. And what they found was both for high-grade soft tissue sarcomas and low-grade soft tissue sarcomas, that there was no difference in overall survival, but there was a difference in local control. So patients who received radiation therapy had much better local control or having the tumor not come back to that original site compared to those patients that did not receive radiation therapy. You can see that here with the separation of the curves. So looking at local recurrence on the y-axis here, what they saw was that radiation almost had no local recurrences in this cohort compared to those who did not get radiation. So as we continue to march down the timeline of treatment of sarcomas, the next question was should you give radiation preoperatively with that smaller field or postoperatively and with that larger field and larger dose? And so this is the Dr. O'Sullivan study. And what he did was he looked at whether or not preoperative radiation could do the same as postoperative radiation. And what they found was that there was no difference in local recurrence, even 10 or 20 years later, if you did it preoperatively or postoperatively, and that really there was no sustainable difference between distant metastases or overall survival. So then I guess it's kind of dealer's choice. Should we do it preoperatively or postoperatively? And why do we think about it in these ways? Well, we have some other data that has kind of helped guide us in what we recommend to patients. And there's trade-offs, as in everything with oncology, of how we're giving treatment, whether and which side effects we're willing to kind of accept and which ones we would rather avoid. So we know with pre-op and post-op radiation that we have the same disease control and the same oncologic outcomes. With preoperative radiation, we're able to give less dose in a smaller volume. And with postoperative radiation, we have to give a higher dose in a larger volume. So what does that mean for our side effects if we're not having an impact on cancer control? So what we saw was that with preoperative radiation therapy, that we have increased wound healing complications. And with postoperative radiation therapy, we have longer term toxicities, things like fibrosis and joint stiffness and edema. And what we know from our current practice of medicine is that those long-term toxicities are much harder for us to treat in the future. We don't really have great solutions for the edema or the joint stiffness or the fibrosis long-term. And our goal is for patients to be living long-term. And so we're trying to also minimize those long-term side effects. What we know with wound healing complications is that this is a short-term side effect and that our surgeons are really good at being able to handle a short-term complication like a wound healing complication. And so for the majority of patients, it really has become preoperative radiation as the recommended treatment choice for high-grade soft tissue sarcomas of the limbs and the extremity. With that, though, I will say that there are a lot of nuances to these treatment decisions. First off, we're looking at the grade, the type of histology, and the size of the lesion. For example, myxoid liposarcoma is really radiosensitive, and so we can actually dose reduce based off of a clinical trial for preoperative radiation therapy. However, some of our well-diff and dedifferentiated liposarcomas are much more radio resistant. And so we actually are looking at ways to think of how can we deliver high doses of radiation to these tumors. It's also a really important discussion with our surgeon. How resectable is this? Is it right across a nerve? Is there going to be, if it comes back, will we be able to do a salvage surgery? What are these considerations as we're thinking about it? And we're always thinking about margin status. Do we think we'll be able to get a negative margin? Is our treatment field going to be so large that it could be detrimental? Or are we making sure that we're being inclusive enough and not too skimpy or small on our radiation treatment? So what I would say is that multidisciplinary discussion is really critical. Here at Mayo, we have a weekly tumor board and we page each other constantly in order to be able to have these discussions and come up with the best treatment for our patients. And so we really encourage that, especially within sarcoma, that your providers are talking with each other in order to help make and guide these decisions. Okay, so I'm switching gears a little bit. So why radiation therapy for the retroperitoneum or the pelvis or the abdomen? So just a little bit of background here. The retroperitoneum is a really complex anatomical space. I list here some of the important structures that run through these areas. And as you can imagine, tumors in this area then become that much more surgically challenging to remove. Surgery is really the only curative option, and there's a need for improvement in treatment. Right now, we are woefully poor at being able to treat these sarcomas. And really, it's a local recurrence problem rather than metastatic disease, which is very different than many other common cancer types. The ability to achieve a margin negative or R0 resection is extremely difficult given this complex anatomy, the need for these really important structures. And these tumors tend to present at a large size since they aren't causing problems until they get too big. So what did we do? We asked, well, it worked. Radiation treatment worked really well for these sarcomas in the extremities. Can we apply it to our retroperitoneal or pelvic and abdominal liposarcomas? And so we looked at the equivalent dose for pre-op radiation treatment of the extremities, and we said, yes, that's a very reasonable dose that we give for other cancers within the abdomen and pelvis. However, the postoperative dose, which is higher, is really too toxic for abdominal and pelvic contents to give a whole big dose of that. The other hard thing is that when we take out the tumor, all of the normal tissues kind of fall back into place. So your bowels, the liver, the stomach, the duodenum, and all of a sudden now we're radiating things in an area that can be too hard to give a cancer killing dose to, but would harm the normal tissues. And so if radiation treatment for retroperitoneal or pelvic and abdominal liposarcomas is given, it's really almost 100% given in the preoperative setting. And so really we don't look at postoperative radiation treatment, only in very special and unique circumstances. And so we tried to do clinical trials in this space. And here we had a really difficult time randomizing patients to either getting radiation or not radiation, and also because this is such a rare cancer form. And so, actually, a working group with an international collaboration across all the continents came into form. And so, it's called TARPSWIG. You may hear about them. They're very active. They publish guidelines as well as clinical trials in order to help guide what we do in this space. And really, in a feat de force, they published what's called the Strauss trial, which was a phase 3 trial that was randomized to patients getting preoperative radiation therapy or no radiation therapy. And importantly, they were able to come up with a conclusion. We'll talk about this conclusion a little bit more, just because radiation oncologists and otherwise, we would just close this up and be like, okay, what they concluded was that preoperative radiotherapy should not be considered a standard of care for retroperitoneal sarcoma. Again, though, there are some caveats with this, and I think it's especially important for our liposarcoma groups in this space. So again, a complete tour de force. They had 31 institutions in 13 countries in Europe and North America that were able to enroll 266 patients. And they randomized patients to with retroperitoneal sarcoma, either to that preoperative radiation or surgery, and then they followed them for a number of years. The endpoint that they were looking at, or the clinical trial outcome that they wanted to assess, was called abdominal recurrence-free survival. And normally we think of things like either local recurrence or overall survival, but this one was a composite. And what they did was they wanted to be encompassing of what was clinically meaningfully significant. And so the investigators defined this as patients who had either progressive disease or increased local disease during preoperative radiation therapy, a tumor that became inoperable, if it metastasized, if they weren't able to get a clear margin type of surgery and leave back behind bulky tumor, and if there was local relapse. However, there was a little bit of nuances with this, as there are with all clinical trials, and they allowed for 8 weeks between the time when a patient was told which one they would be getting and the beginning of radiation therapy. And what we know from these tumors is that they can grow even during radiation and between the time of when a study is initiated and when a patient starts getting treated. And that doesn't necessarily mean that they're not able to go on and have a good resection and not leave behind bulky disease. And so when you looked at it just in terms of the two curves, preoperative radiation therapy and surgery alone looked no different between the two. However, 15 of 19 patients who were said to have progressed on preoperative radiation therapy went on to have a completely good resection and actually did very well. 3 patients had developed distant mets during radiation therapy, so that may suggest that this wasn't a radiation problem, but that the tumor had already advanced so far that it was now in a metastatic setting. And then 1 patient actually developed a poor outcome during anesthesia. So the overseeing group that overlooks their clinical trial said, you know, we have to kind of rethink this endpoint. We also want you to do some further analyses. One thing is that if a patient is not doing well because of overall general health things like cardiac disease or health issues, let's not count that toward against radiation, but rather let's put that into a different subcategory because we're really interested in how radiation treats in the local area. And the other thing that they said was, even if the tumor grows with radiation, which can happen because of the tumor having swelling or the tumor having an immunologic response, let's also not count that against radiation and look at local control. And so when they did that, it actually preoperative radiation therapy decreased the number of recurrences by over half. And this was statistically significant and of points to that there still may be a role for radiation therapy when we're worried about local control in these retroperitoneal sarcomas. The other thing that's really important is that, as we've talked about for many of these trials, they group all of the sarcomas kind of together. And we know that these histologies are very different. And so they said, okay, let's look at liposarcoma specifically. And here they saw a trend towards improved local control with preoperative radiation therapy for liposarcomas and low-grade retroperitoneal sarcomas. This was not seen for leiomyosarcomas and high-grade retroperitoneal sarcomas. So again, really pointing to the fact that we have to think about histology specifically, especially for our liposarcomas, and the role of radiation in these retroperitoneal sarcomas. And we know this to be true when we look at big data sets of how different histologies do. Well-differentiated liposarcoma has the best overall survival, and then we compare this to dedifferentiated liposarcomas in even different grades. And so again, we have to think of each patient and each patient's histology for their treatment in order to know which one is best. And when we think about this, we have to think about what's the local control risk and what's the risk of it metastasizing. And again, liposarcomas, whether they're well differentiated or dedifferentiated, and their grade will make a difference in how patients could progress in the future. And so when we think of these multimodality treatments, we have to weigh all of these factors in order to think of the systemic therapies and the local regional therapies, including radiation treatment. So what are we actually treating? These things are things that you'll maybe hear your radiation oncologist talk about. It's how we talk to our dosimetrists and our physicists. And we talk about gross tumor volumes and clinical target volumes or microscopic disease. And again, well-differentiated looks more like typical fat, whereas dedifferentiated liposarcoma looks more like a tumor. And so it's very important that your radiation oncologist and your surgeons and your radiologists are well-versed in being able to look at these types of scans, because well-differentiated liposarcoma in this background can look a lot like normal fat. And we have studies that suggest that when we accurately target where we're treating with radiation therapy, that this is very important for local control. The other thing that's new and exciting within our field is thinking about how can we get more dose in to treat sarcomas. And so again, we're looking at whether or not we can give boosts to areas, since we can't give it to the whole area as it's too toxic for the normal tissues, to areas where there's the greatest risk of the tumor coming back or the surgeon having the most difficult time reaching and getting a clear margin. So there is a phase 1 dose escalation in proton therapy that demonstrated safety, and the phase 2 results of this multi-institutional study are expected to be released soon. And I'm hopeful that this will show that we can give a higher dose with better local control for our patients. And this really requires exquisite collaboration between surgeons and radiation oncologists to be able to define these margins. So what advances are there coming down the pipeline here, and what are we excited about of different treatment options? So one of those are hypofractionation, so being able to give less overall number of treatments for patients. Spatially fractionated radiation therapy, which is a specialized form of radiation where we're able to give areas of high dose and low dose radiation. Stereotactic body radiation therapy in the setting of oligometastatic disease, or where we think of metastases only being in a few locations. And then intraoperative radiation therapy is also an area where we're always exploring. And so hypofractionation, why are we interested? So compared to that conventional radiation treatment, we actually give a larger daily dose per fraction, and it's delivered over a shorter treatment time. I asked ChatGPT to create an image of this for me. And so this is what it came up with the microscope, the ionizing radiation, and then the equations that we use in order to calculate what these doses are. And I will say it came up with quite a cosmic looking way of our delivering of radiation treatment, but it wasn't that far off. So within the lab, we've looked at sarcoma cells and looked to find what kind of doses of radiation are required for cell death. And that's where you'll maybe hear someone say, oh, it has a low alpha beta ratio, which means it actually requires a lot of radiation to get good cell death. Our normal tissues, though, don't require as much. And so what we know is that if we give a bigger dose per fraction, we may actually have a biological advantage within sarcoma of being able to kill more cancer tumor cells and preserve our healthy tissues to be able to regenerate. The nice thing is too is that this is a shorter, more convenient treatment schedule for patients. Many patients don't live around large sarcoma centers or those with radiation treatment capabilities, and so they need to travel distances. So our ability to deliver a shorter time frame of radiation is very exciting. It also gives you a shorter time to your next step of therapy, whether that's surgery or systemic therapies. And really, this was also largely driven during our COVID-19 epidemic when we knew we need to optimize our resources and get patients in and out. And so it really provided a catalyst in a challenging time to further investigate being able to give these hypofractionated courses. And what we knew from other cancer types that are much more common, like breast, prostate, and rectal cancers, is that this is a standard of practice to give hypofractionated radiation treatment. And so within sarcoma, which included the liposarcomas in the extremities, two phase 2 trials have been completed and reported and published at MD Anderson and here at Mayo. And what we saw was that in 3 weeks given, rather than the traditional 5 weeks, that there was excellent local control and comparable wound complication rates. We're still waiting on longer term data, and there is suggestions that for the majority of patients, it is equivalent for long-term toxicities. There may be a subset of patients where if the tumor is wrapping too much around bone, that standard fractionation would be more acceptable for longer-term fracture risk. But again, we're still waiting for the maturity of this data. Excitingly, a phase 3 randomized clinical trial from Europe, so where patients had a coin flip to whether they would get 5 weeks or about 3 weeks of radiation, is expected to be reported on later this year. And so we await these results to be able to hopefully be able to offer these 3 weeks of treatment as more of a standard of care. There's also interest in further hypofractionation. So if we can get it down to 15, could we get it down to 5? And so that's an area of active investigation by a number of different groups. So next up is one that's close to my heart, which is spatially fractionated radiation therapy. And this can also be heard of as called grid therapy or lattice therapy. And it's really because it looks like a grid or a lattice applied to a tumor. And we're giving geographical regions of high dose radiation and low dose radiation. This likely has immunologic and other tumorigenic effects, and it can be good for bulky radioresistant tumors like liposarcoma. And so our goal is to be able to create areas of high dose radiation and low dose radiation to encompass all the different biologies that radiation treatment can cause. And so at Mayo, we've published a number of papers looking at this. And what we saw was that if we gave grid therapy to these large bulky tumors, that there was a good subset that actually responded to the treatment, whereas in more conventional fractionation, we wouldn't have seen such a large response. This can be delivered using photons or protons. It's typically utilized in the metastatic or unresectable setting. Really, our studies are too small right now for specific sarcoma subtypes, but they have included liposarcomas. And we're excited that biological correlates with these studies could provide further insights and synergies with systemic therapies. And we really need more clinical trials within this space. Here at Mayo Clinic, we have published on our experience where we have treated patients with metastatic or unresectable sarcomas, and they got a single fraction of this grid or spatially fractionated radiation therapy, then followed by kind of more conventional or hypofractionated radiation treatment. What we saw was good local control rates in the 80% range, that symptom relief was over 60%, and that there was stable or partial response in 90%. When we always look at these studies, we also want to look at toxicities, and there was one patient that required surgery due to a toxicity from this treatment. And so what can this look like with radiation? So this was a proton treatment plan where we're delivering those high dose areas, or that bright red and yellow, to the inside of the tumor and sparing the normal tissues around it. We then give that lower dose radiation to the whole tumor in order to be able to also control microscopic disease and hopefully elicit more of an immunologic response. We're also doing SBRT, or high doses of radiation to metastatic sites, and this can be delivered in precise areas. We now know metastatic disease to really be a continuous spectrum rather than just a sudden diagnosis of metastatic and stage 4 disease. And oligometastases, where there's only one or two, maybe less than 5 treatments or 5 sites, could potentially give us a window of treating all of the disease in order to try to give a longer duration of no further therapies. Again, though, we always have to balance potential toxicities and local control. And so with that, I'll conclude, and then we can get to our Q&A time. So radiation plays an integral role in the treatment of liposarcoma. This can be in the curative setting, whether we're looking for disease control, or palliative setting to help relieve symptoms. I'm excited by our new technologies and advances in biology, and we're working to increase efficacy in order and also decrease the side effects for the benefit of our patients. And so with that, I'll open it up for questions.
Thank you so much for your presentation. We really appreciated all the information. We'll now move on to our Q&A. As a reminder, participants, please submit your questions through the Q&A and we'll address as many as time allows. We received the question in advance. It's kind of a two-part question. And Dr. Lee, you did cover some of it, but I'll just read it again and then you could answer it. Can radiation therapy be considered after surgery as an alternative or adjunct to chemotherapy in liposarcoma?
So yes, radiation treatment after surgery can be considered for liposarcoma. I think of it again as a local control issue. So if there's things like positive margins or no preoperative radiation treatment was given beforehand, and there's a high risk of the tumor coming back and causing problems. With thinking about it with chemotherapy, we always work with our medical oncologists to discuss whether it can be delivered simultaneously or needs to be done in a stepwise manner, since the chemotherapies or immunotherapies can add further toxicities with our radiation treatment. The nice thing, though, about those systemic therapies is that they work all over. So if there's a high risk of metastatic disease, then we'll usually turn to our medical oncologist to help with treating everywhere rather than just the local tumor space.
Thank you. If so, and then also what subtypes or situations might this approach be appropriate? And is there someone specifically they should contact?
So in terms of if there are different liposarcomas or subtypes, I would say it is very dependent on histology, and it's also dependent on histology review. So we recommend that histology be reviewed at a large sarcoma center, since there can be nuances in determining which types of sarcoma. Again, because there's so many subtypes, it's hard to give a specific answer, but for most sarcomas, talking about adjuvant radiation therapy is an important multidisciplinary discussion. So I would recommend contacting a sarcoma center if interested in kind of further delving into the specifics of their case.
Okay, thank you. A second question we received for dedifferentiated liposarcoma. How is curative intent defined?
So dedifferentiated liposarcoma and curative intent. So I can think of it in terms of all kind of sarcomas and cancers. With curative intent, it means we are trying to get rid of every single cancer cell and create a, a remission. So not having cancer come back within your lifetime. Granted, though, when we say cure, it's a really hard thing to say as an oncologist because for some, cure can be a period of years to a whole lifetime. And so, what we're doing, though, is kind of throwing all the kitchen sink in order to get rid of all the cancer cells in order to achieve the possibility that the cancer never comes back.
And the next question was, when post-radiation tumor shrinkage is observed, how do you determine whether this reflects true tumor cell death?
Hmm. So that's usually done at the time of surgery. So if the surgeon, the tumor is then resected, the pathology report will usually say how much treatment effect was seen and whether it's cell death or fibrosis. And that can have, there are thoughts that how much cell death or fibrosis occurs from the cancer pre-treatments, like with radiation therapy, can have an impact on how well the patient will do. Again, though, it's still too early for us to fully know what that threshold is or exactly what we're looking for on pathology, but it's really only after a pathologist looks at a tumor that's been taken out after radiation therapy do we know how much cell death has occurred.
This next question is related to recovery after radiation. It says many patients experience prolonged side effects. Why isn't there a more standardized radiation rehabilitation model?
That is a great question and one that I think we could all do better at. And so I tell my patients that radiation continues to work in your body even after the beam is off. So you're not radioactive in the ways that we talked about in this presentation after treatment, but that biology is still occurring. And so the recovery of the cells, the fatigue of your body going through all of that treatment, all of that's going to continue in the weeks to months following radiation. I think that unfortunately, as an oncology field, we haven't thought enough about the long-term effects. And especially now that we're able to help patients live longer. And so with that comes we are getting patients to living longer, but it also means that they're having to have these longer term side effects. And so I think that this is an area where we could all improve and more studies need to be done so that we can have better solutions.
Thank you. Another question is, can you discuss re-radiation in liposarcoma and whether this is ever an option in practice?
Yes, so reirradiation, I would say, is a very individualized discussion with a radiation oncologist, especially one who sees a large number of sarcomas and is a very adept at reirradiation. There's a number of factors that come in with reirradiation. For example, how much time has passed, what it's near in terms of normal structures, and what that prior radiation treatment plan looked like. We utilize different technologies in order to, again, try to decrease the potential toxicities that are definitely increased with reirradiation. But it is a very nuanced discussion, but it's definitely a possibility and should be talked about with a radiation oncologist who's very used to kind of treating in those settings.
Okay. This one's a little specific. It says, if a tumor is wrapped around SMV, SMA, can radiation be used in that area? Is it safe?
Yes, so the SMV and the SMA, that's the superior mesenteric vein and superior mesenteric artery. And yes, I have treated many patients with tumors that are wrapped around those areas. Again, we kind of take a lot from our pancreatic cancer colleagues, since this is where a pancreatic cancer can also be. And so we are able to utilize kind of how they treat as a way of with radiation treatment. Again, though, it requires kind of the look of the radiation oncologist and knowing what they can do for safety and efficacy, but it is possible to treat in that area.
Would medicinal liposarcoma come with different radiation parameters or cautions, benefits than retroperitoneal or limb post-op?
Oh, I may have missed the first part. Medicinal, like,
Sarah? Mediastinal?
oh, mediastinal.
Yeah, sorry.
Okay, yep, that's okay. So mediastinal or mediastinal liposarcoma. Again, so I also my other hat is kind of the sarcomas in the thoracic space. And so those are even rarer than the retroperitoneal sarcomas, and that requires cardiac thoracic surgery and a radiation oncologist. Again, though, there are the same thinking parameters, kind of the preoperative radiation question, surgical resection question, and the postoperative radiation question. And so, again, a multidisciplinary discussion about a specific case.
Thank you. What is the estimated percentage of collateral damage with types of radiation that could lead to secondary cancers as seen in pleomorphic subtypes?
So I don't know of specific numbers in terms of kind of the risks with pleomorphic subtypes, but I would say that there is a risk of secondary forms of cancer from radiation, and those typically are sarcomas. And we know this from the treatment of our more common malignancies like breast cancers and rectal cancers, that there is a very, very small percentage of patients that then get a radiation associated sarcoma. It's actually harder for us to know with sarcomas, and we're treating sarcomas if we're causing a new form of sarcoma. So, what we think of in a radiation associated sarcoma after it's been already treated for a sarcoma is that it needs to be a different type of sarcoma, because that would be what is most common. Those things happen 10 plus ish years after radiation treatment, and it's thought to be in the very, very low percentage ranges based off of kind of our high volume radiation data.
Thank you. Can you discuss CyberKnife, SBRT in the retroperitoneal dedifferentiated liposarcoma post-op and after IMRT?
That it's a little bit of a specific question. So I would say that so just generally, so CyberKnife and SBRT are a very conformal high dose form of radiation given usually in 1 to 5 treatments. This can be one of the ways that we treat kind of oligometastatic disease or very small areas of tumor. If, again, if there's one very small area of post-op in a retroperitoneal sarcoma, that's usually pre-discussed with a surgeon and is highly specific. After IMRT, again, that's in a re-irradiation setting, and so it's a very nuanced discussion, and also considerations for other particle type therapies like proton therapy would be something that would want to be discussed.
Do you have any recommendations of care with Medicare coverage?
I think that one is a little bit outside of my expertise, unfortunately. And so, what I always tell patients, though, is the large volume centers, if covered, right, is a good place for sarcomas since they're so rare, and it's good to have people who've seen it before.
Thank you. In the future, do you see cryoradiation becoming a post-op option?
Hmm. Uh, I'm don't know if I'm as familiar with cryoradiation. So there's cryotherapy where it's kind of the freezing of tumors and it's done by our interventional radiologists. Cryotherapies, I think, and other ablative therapies are also an excellent tool that we, again, collaborate a lot with because different tools have different side effect profiles. And so, in order to maximize kind of what we're able to offer the patient, we like to maximize different therapies. So, I am hopeful that we're able to utilize kind of all tools of the tool basket for treatment for our patients.
Thank you. And I think that's about all the time we have. Really, thank you for answering all the question and answers, for your presentation, your expertise. Thank you for all that joined us today. We hope the discussion has provided valuable insight into the role of radiation in liposarcoma. This webinar has been recorded and will be posted on our YouTube channel within the next few days. We also encourage anyone attending to visit our website, the Liposarcoma Support Network, to explore the resources that we have. There's clinical trial information, educational programs, additional previous recorded webinars are on there. All of these resources are designed to help you better understand liposarcoma and navigate your journey. We are also still leading a global advocacy effort urging Boehringer Ingelheim to reverse its decision to halt the development of Brigamadilin. So we ask that you please sign and share our petition. It's at brigamadilinpetition.org. Every voice matters, so please share and sign when you have a chance. And on behalf of the Liposarcoma Support Network and the Life Raft Group, we sincerely appreciate your participation. Please don't hesitate to reach out and let us know what additional programs or resources might be helpful, and we look forward to connecting with you at future programs. This concludes our webinar for today, and thank you for all attending.